So I'm going to talk to you a little bit about irrigation aspiration, IA. It's something we don't really think about very much, we just do it. But as a trainer and somebody who's done quite a few cataract operations, it's something that is becoming more and more important to me. So I'm going to ask you a few questions. So why do we do it? What instruments do we use, and why do we use each one? And how can we do it better? So why do it at all? I mean, you don't have to. Why do we do it? Taking the cataract out, disassemble the nucleus, so all the bulk of this stuff's out. Why do we do it? Well, the main reason is to reduce post-operative inflammation. The material you leave behind is anaphylactic, it's immunogenic, it's not been exposed to the human immune system, and therefore it'll cause a lot of cystoid, some iritis, and it will be uncomfortable and painful for our patients. It may cause some corneal edema as well, so you've got to get it all out. The other reason is the whole purpose for doing the cataract operation is to remove the opacities within the visual axis. And this is an opacity and it's right on the nodal point of the eye, so we want to take it out. And lastly, one of the main complications of a cataract operation is posterior capsular opacification. And if you leave material within the capsular bag, it's going to act as a nidus, and more material is going to come out, more scarring is going to occur as a consequence. So I'll just go through a few questions. It's like, should I remove every little bit? These are sort of questions that you get asked. Should we do some polishing? Take away all the anterior cells on the front of the capsule? And the other main question is like capsule rupture and how do we avoid it? So should we remove the tiny little bits? Well, this is a paper that I released ancient history now, 30 years ago, which I did with David Spalton, Lynn Pandy and Emma Hollick. So these are pictures taken at 3 months, 6 months and a year after cataract surgery. And you can see there's been some growth here, probably due to some residual epithelial cells that were left behind on the capsule. And they regress. So if the lens is in the bag, like this one is, the pressure that the bag exerts around the lens just causes it to regress. And PCO is a slightly different process that occurs. So these little filaments here are probably not that vital. And in that respect, it doesn't really matter too much if you take them out. So it's important to get everything out, but there is a degree of circumspection you have to have that you don't really need to get everything out. The next question is polishing. PCO grows from epithelial cells which are left behind, usually in the equator, and you can get at them if you go under the anterior capsule on the inside and remove the cells from here. And some people get very exercised about this. It doesn't make a whole heap of difference, to be honest with you. There's various reasons for that. First of all, the epithelial cells that are going to cause PCO are right out in the equator, right out here. And these guys are metabolically active, dynamic cells. The cells are a bit more sleepy and dormant up here, and as they come towards the equator, they get really going. And these cells, because they're so active, are firmly stuck to the basement membrane, which is the capsule, and therefore removing them is going to be very difficult because they're stuck down. And also technically getting your instruments right out to the equator and removing them out here is going to be difficult. So the ones you take out are the guys up here. And these are a bit more indolent cells, and they're not the ones who are causing PCO. So there's been quite a few papers written about this, some randomized trials and things. If you want a really good review of this, Oliver Findle produced one in Eye last year, 2020. The take-home message is that it won't make any difference on posterior capsular opacification, but it will reduce anterior capsular fibrosis if that's something that concerns you. The main issue, though, with IA is safety. You see this, and you see the little lines, and you've grabbed the posterior capsule. Now, if I'm a trainer, my blood pressure immediately goes up, and if I'm actually doing the surgery, my blood pressure probably goes up even higher. And this is an imminent danger sign that you're going to damage the posterior capsule and cause a posterior capsular rupture and vitreous loss. So you see these lines, you've got to basically, in a normal situation, you've got to try to stop aspirating, allow the capsule to fall backwards away from your instrument, regurge if you have it available on your instrument, and pray that you haven't busted the capsule. So how common is this? What has happened? So I'm going to take you through a few sort of slightly abstract ways of looking at this. So first of all, this is a paper from ancient history. Again, this was from the 90s. This is when we were converting from extraCap to phaco. And Mike Burton was a very experienced VR surgeon who documented his first 3,000 cataract operations and when he bust the capsule. Now, this is in the early days of phaco, so the instruments and the machines are a bit more primitive than what we've got now. But he was causing capsule rupture a lot more commonly during phaco than IA when he was learning in his first 1,000 cases. When he came to his third 1,000 cases, i.e. he'd got over the learning curve, he was causing capsule rupture and breaking the capsule equal amount of frequency between phaco and IA, which tells me that when you're a trainee or if you're going through the learning curve of learning cataract surgery, once you get the hang of it, you'll break the capsule less during phaco, but you'll still have it happen during IA. This is a large review of about 50,000, retrospective review of about 50,000 cases in the States. It was published a few years ago in the American Journal. And it shows that if you look at when PC rupture occurs, it occurs about 60% of the time during phaco and about 25% of the time during IA. And this is something that we need to be bearing in mind, that it is quite a common occurrence that we break the capsule during IA. And also, trainees and residents had more of it than consultants. And if you ask trainees and residents how do they score cataract surgery, obviously capsulorhexis and phaco is difficult. It's a 92% and 83% of difficulty. But IA doesn't come far behind. Nearly 80% of the time they're finding it difficult. And so this means that trainees do find it difficult because they're worried about busting the capsule, and with good reason. If you look at what instruments people use, it's difficult to really tell. It's obviously something that's not really common knowledge. So I went and asked a few of the reps when they started coming to theatre again after the pandemic, roughly what figures did they think were going on when they went into theatre around the country. And we reckon, this is very back of the envelope, rough and ready figures, still a few people using Simcoes, and it's about 2/3, 1/3 coaxial and bimanual. And of these coaxials, some of the instruments are reusable and some are disposable. Some have got silicone sleeves, some haven't, some have got silicone tips and some haven't. Now, one of the big problems of using a metal tip, either it's reusable or if it's disposable, is the quality of the metal at the end. Now, if this little burr, you've got little burrs and nicks, and as you grab the capsule, this is going to act like a little knife and break the capsule. And David Lockington produced a lovely paper earlier this year in which he took a bunch of available metal tip IAs and did scanning electron microscopy of them, which showed that there was lots of little nicks and burrs around the instruments which could break the capsule. So this is the metal, this is the lumen inside. You can see there's all sorts of bits and bobs around here that could act as little areas which will break a capsule if you capture it. So MST have developed this very nice instrument called the Allegro, which has got silicone all the way around. So if you look here, you can see the silicone is what's going to grab the capsule if you do grab it, and the metal aspiration area, it's got a little flange at the end, which means it abuts and sits very nicely against the silicone, which means it doesn't stick out, and you're never going to get this bit of metal coming out of the end of the silicone. So the only thing that's going to hit the capsule is the silicone, which means it's much safer. Again, because this has got silicone sleeves, this gives a very nice seal in your wound. So this is a video that's not mine. This is from David Allen in Sunderland, just showing how you use this. And you can see that there's a little hole at the end, which is the aspiration port. And what I want you to look at a lot of these videos, you watch the tip and see it happening, but also watch here. As you can see that there's a very tight seal, a bit like a phaco instrument, and you can maintain your anterior chamber stability, again, which means you're unlikely to grab the capsule. So they have a very good ability to perform their primary task, which is to do IA. But because the silicone end is very safe and protected for the capsule, you can just go away, and if you do want to take away some of the little filaments at the end, you can filaments off the posterior capsule, you can do that with real ease. Because it's quite a strong structure at the end, the metal aspiration area is close to the silicone at the end, gives it quite a bit of strength, So if you do get some harder material that it's difficult to take out, you can just ease it up the end quite easily with your second instrument, as it's not too floppy that it will do that. Because these instruments are so safe for the capsule, my surgical technique has changed a little bit in the fact that I actually do less phaco than I would normally do, and I bail out much earlier and get to IA because I know that once I've got to this stage, I'm never going to break the capsule. So why is that? Well, we started using these a few years ago, and we realized that trainees were grabbing the capsule and it wasn't breaking, and my blood pressure started to go down. So we did an analysis of this, looking back at the 2 or 3 years before we started using a soft tip IA and the 2 or 3 years afterwards. And we found about 780 cases and 900 cases done by trainees before and after. So this is with a variety of different types of IA instruments, and this is with the soft tip only. And our PC rupture rate went from 28 to 15 amongst the trainees. What we then did is we knew who all these guys were. They're our local trainees, and Laura Morgan, who did the work with me, phoned them all up and said, do you remember when it happened? And most trainees, it's pretty ingrained in their minds, and they said, yeah, the PC rupture happened here or there, wherever. And we could then work out when, during the operation, the PC rupture occurred. If it was with the conventional tip, it was 12% happened during IA, and with the soft tip, none. So we could see all the different times in the operation during the capsulorhexis or during the phaco, during IA with the conventional metal tips, with the soft tips, no PC ruptures occurred. And this we think is why our PC rupture rate dropped from 3.6 to 1.6% when we introduced this instrument. And it's now mandatory for all our surgeons, consultants and trainees to use it. Published it a couple of years ago, and it also fits in with a big study that was done earlier in the States showing PC rupture rate during IA dropped dramatically with the introduction of soft tip IAs. So PC rupture occurs during IAs. We think we kind of forget about it, and it occurs because we grab the capsule inadvertently and break it. PC rupture is bad. You do not want to have it, and anything you can do to prevent this from happening is going to be better for our patients. That's a PC rupture, means they're going to get detachments, going to need more surgery, and their visual outcome is going to be worse. And by introducing a soft tip IA into our armamentarium, we have eliminated this element of PC rupture, which makes it better for patients and certainly better for my coronaries. Thank you very much indeed.